Hello, my name is Prangwipa Malakan. I am from Group 2. I will present the topic of impact of Affordable Care Act on trauma centers. The members in Group 2 are Prangwipa Malakan, Oveys Mansuri, Hesty Tumangke, and Rongisch. An overview. I will start with introductions, then following with provisions of Affordable Care Act that related to trauma centers, how Affordable Care Act impact on uncompensated trauma care, non-profits, tax exemptions, and charity care. Then I will finish with trauma system financings, funding mechanisms, successes and failures, cost, and Affordable Care Act implications. In the U.S., trauma care is the second leading cause of healthcare financial spending. It also requires a wide scope of patient treatment, such as multiple specialists and expensive care, which accounted for 10% of the U.S. healthcare expenditure. Due to rising healthcare costs, the government passed Patient Protection and Affordable Care Act in 2010. It also called Health Reform Act, which has significant impacts on trauma care. The ACA authorized $224 million for trauma and emergency service programs and activities. This amount of money are separate into three grants. First, $100 million for trauma care center grants. The majority 70% of grant given to assist trauma center from uncompensated care costs, 20% to maintain trauma center core missions, and 10% to provide emergency support to trauma centers that are at risk of closure, and to ensure availability of trauma center in needed area. Second grant is for trauma service availability. This will be given through the states and used for a wide variety of operational and capital expenditure, including physician compensation and capital expenses. Another grant is for regionalized systems for emergency care response. This grant will be used to support pilot projects that focus on communication and transportation across the region to ensure that patients get proper medical care in timely fashion. Another provision that commonly well known and has significant impact on trauma care is expansion health insurance coverage. This will decrease the number of uninsured and therefore decrease uncompensated trauma care costs. A study tried to figure out how much relief can trauma centers expect from Medicaid expansions. So the study simulated a scenario where all uninsured were covered with either Medicaid or Medicare, and the result showed that trauma centers will continue to suffer from losses at around 3,000, even though this is at a lower rate. This section, I'm going to talk deeply on how ACA impact to uncompensated trauma care. About 15% of trauma patients are uninsured, leading to a large amount of uncompensated care. Between 1990 and 2005, about 30% of trauma centers closed, mostly because of financial reasons. The ACA will introduce roughly 33 million newly insured people, but there will still be an estimated 23 million people without insurance that will continue to burden the system. Not-for-profit tax benefits and charity care write-offs used to deal with the large uninsured and underinsured populations served. To qualify for tax exemption, The IRS requires nonprofit hospitals to allocate a portion of their operating expenses to certain charitable activities, such as providing free or reduced care to the indigent. Growing concern that nonprofit hospitals were not providing sufficient benefit to their communities to justify their tax-exempt status. Concern has prompted the IRS to require that these hospitals formally document their contributions to the community on IRS Form 990 Schedule H. These new requirements make nonprofits more transparent to the IRS and the public. The biggest impact will come from the individual mandate and from the expansions of Medicaid. By 2019, there will be an expected 25% reduction in uncompensated care spending due to the individual mandate alone. An estimated 8% of the population will still lack meaningful coverage by 2019, resulting in an estimated uncompensated care expenditure of $47 billion. It is possible that a further concentration of charity care will occur, and that hospitals located in inner-city areas with high poverty may not see demand for charity care decrease. In a recent report by the American College of Surgeons, 42 states have statewide trauma systems, and 24 of these are in some part funded by the states. Some of the funding mechanisms used by the states include fines and fees on moving violations, additional fees on motor vehicle legislations, license plates or driver license renewals, tax on cigarettes, fee from criminal penalties, and state general revenue. From the pie chart, it shows that the most three common mechanisms that have been used are moving violations, criminal penalties, and motor vehicle registration and license fees. Funding mechanisms have both success and failure. The success examples include legislation in Alaska leading to a fund to support certified trauma centers. Georgia passed super speeder legislation resulting in fines for excessive speeding, and Arkansas increased its tax on cigarettes and smokeless tobacco products. Despite innovative success, there are also failures, both in attempts to fund and funding programs themselves. One such example was the Emergency Medical Care Initiative in California, which was designed to add a 3% surcharge on telephone usage. However, it failed with 72% of voters opposed to the measure. In New Jersey, a cosmetic surgery tax of 6% was expected to generate $24 million per year toward reimbursing hospitals for charity care. However, actual revenues were $7.8 million. Later on, the tax was repealed in 2012. The cost of being ready and available is a concept of trauma readiness. There is an implicit cost to maintaining preparedness and readiness for trauma patients. One study estimated that costs of maintaining Level 1 trauma centers were $3 million per year, with the cost of a safe life at $87,000. The UB92 billing process in Medicare and Medicaid offer opportunity to improve revenue and collections for unfunded care. Last but not least, the implications of the ACA on states. Affordable Care Act and state funding of trauma care need to have public-private partnership to expand access to insurance and thus improve access to care. U.S. Supreme Court affirmed that the individual mandate was constitutional. However, Medicaid expansion was not constitutional. States can determine whether they want to participate or not. The impact is that about half of the states refuse to participate in Medicaid expansion, and more importantly, more than half of the people without health insurance actually live in those very states. Another implication is that will the new reimbursement equilibrium among private insurance, Medicare, and expand Medicaid be sustainable for trauma centers? Will ACA and federal government expand its investment in trauma care beyond the cost of administrative support? These questions need to be answered, which hopefully we can figure out when the ACA is fully implemented. If you need more information, here is the reference that we use for the full paper. Thank you for watching. Please ask if you have any questions.